it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Thanks everyone for joining us tonight. It's certainly a topic that as rheumatologists we find very exciting and love talking about. So I hope you enjoyed, and yes, we do welcome lots of questions, but at the end, because hopefully we'll answer many of them as we go. So thanks for joining us, and yes, we're going to be demystifying biologics tonight. So the first thing really that I'm sure everyone would like us to address is, what are we talking about when we refer to biologic drugs? What in particular does a rheumatologist mean when we talk about biologic drugs? So really, it's important to know these are advanced therapies that we use to treat a whole range of rheumatic conditions, and they're not just used to treat rheumatic conditions; they treat other conditions too. But as rheumatologists, we're talking about the ones that are used to treat rheumatic conditions. The big benefit of biologic drugs is that they are often effective, even if traditional therapies such as methotrexate have not achieved adequate disease control. And what makes them advanced, or what makes them special, is they target very specific parts of the immune system in order to reduce inflammation and damage. So it's that very targeted nature which is what makes them so advanced. And why do we call them biologics? Well, it's actually because the first of these types of drugs that became available were actually made by organisms and cells. So they're actually biologic products. And so they got the name biologic drugs. Now, not everything that we call a biologic these days is actually a biologic, but we still use that term. So that's the term has stuck. So that's why they're called biologics. So just going a little bit deeper to try to explain how this works and why they're so special, and why we use them the way that we do. So on the right here is a joint, and it could be, I'm using the example of rheumatoid arthritis, but this could equally be a joint in psoriatic arthritis or ankylosing spondylitis. And really, this is a schema for inflammation of any type. So even other conditions that don't involve joints but do involve inflammation in the immune system. There are so many different factors that actually go into creating inflammation and perpetuating inflammation. So there's an inflammatory cycle that really develops. And there are lots of different cells. There's lots of different molecules called cytokines or antibodies, and they're all involved in this. So it's very complex. The idea with biologics is that they're designed to pick one of these and block that one thing specifically. And the idea is that then breaks the cycle of inflammation. And different biologics will be targeted to block different parts of the inflammatory cycle. So that means that if we try one of these drugs and it doesn't work, then we can try a drug that actually targets a different part of the inflammatory cycle, and perhaps that will work instead. And also it's important to note that for different conditions, the exact type of inflammatory factors involved is subtly different. So a biologic drug might work in one condition, but not work in another condition. And just to take you on a little bit of a journey of how we arrived at biologic drugs. So up until the late 90s, early 2000s, that's what we call the pre-biologic era, before we had access to biologic drugs. And so this is the example of rheumatoid arthritis, but the drugs that we had available included non-steroidal anti-inflammatories, steroids, methotrexate, Plaquenil. So things that you may be familiar with. These are considered to be traditional or conventional anti-rheumatic drugs. And they are not very specifically targeted. They're drugs that maybe came about because we noticed that there was an effect, but they're not specifically targeted to one part of the inflammatory system. but they are effective. And for most patients, they can control disease. And, it's also important to note that they have a different side effect profile from biologic drugs. So, every drug has potential side effects, but it's still appropriate to start treating with these drugs first because they are very often effective, and they're usually well tolerated. So we still start with these medications. But since the late 90s and early 2000s, we've had an explosion of biologic drugs become available. And so this, all the ones in blue there are biologic drugs that are now available. And this goes up to 2017. And even in the last 6 years, we've probably can add another half dozen medications to that list. And you can see, so now we're operating in this biologic era, and these medications are often, as I said, effective when the traditional drugs have not been effective. You'll also notice that there's a couple of orange names thrown in there as well. And these are also targeted medications. They're also very specialized, but strictly they're not biologics. They're not created by cells and organisms. But as rheumatologists, we still use the term biologics to describe all of these advanced therapies. The advantage of these orange ones is that they can be taken as tablets. And that leads me to the idea that biologics come in a whole range of different, forms, essentially, shapes and sizes in a sense. So you can see there's a few examples on the left of injectable biologics. And so these ones can come in either pre-filled pens, which are quite simple to use, taking a cap off and pressing them into the skin with a very, very small needle, or in a syringe where you can actually control the injection yourself. And then, as mentioned, there are some of these targeted therapies that come in the form of tablets now, which is pretty recent. So to go into more depth about this, Kate's going to take over the slides now and speak a little bit more to specific conditions as well. So I'll hand over to Kate. Thank you.
Thank you, Nick. So now that we understand a bit about what biologics are, I'm going to go through some of the most common conditions that we use biologics to treat and some of the most common biologics that we use to treat the conditions. I'm going to stick to the most common biologics and conditions as there's just so much to cover, we wouldn't be able to cover it all in the time we have. It's important to note that the government has strict criteria of who can access biologic medications. And so generally patients are required to try the simplest treatment options first and then only progress when they still have active disease. Often multiple biologics are available for each condition, and not all the risks for each biologic is exactly the same. So the decision of what biologic you use should be a personalized discussion that you have with your treating rheumatologist. We'll go to the next slide. So the first condition I'll speak about is ankylosing spondylitis or non-radiographic axial spondyloarthritis. So I actually did another talk on Connect about this, I think earlier this year. So if you wanted to have a look at that, you can learn more about the condition, but it is a condition where you get inflammatory back pain. And to make this diagnosis, you're required to either have a positive X-ray or MRI. Often these patients have a very good response to anti-inflammatories in an exercise program, and everyone should have a trial of anti-inflammatories in an exercise program. But if despite doing this, you have high inflammatory markers, you can access biologic treatment. The first class of biologics I'm going to talk about is TNF inhibitors. So TNF inhibitors are available for the back inflammatory conditions, but they're also available for other conditions. And this includes rheumatoid arthritis and psoriatic arthritis. So these are biologics that target tumor necrosis factor. So in that diagram that Nick showed us, it's one of those cytokines that drives active inflammation. So we have lots of experience with the TNF inhibitors, and we have good safety data because these have been available since the 1990s. There are lots of different TNF inhibitors available. I've listed them all here. There's adalimumab, etanercept, certolizumab, golimumab, and infliximab. There's also different brands of TNF inhibitors within each name. So for example, adalimumab, there's multiple different brands available because they're off patent. And the decision of which one to use for you will be an individualized decision. They have different dosing intervals. So some of these are injectable weekly and some of these are injectable monthly, and they all have different risks and benefits. Certolizumab is actually the preferred agent for pregnancy of any biologics, and I'll discuss that later when we discuss specifically about pregnancy and biologics. With the TNF inhibitors, there is specific risks to this class, and then there's the risks that are with all classes of biologics. But specific to TNF inhibitors, we need to ensure that patients don't have tuberculosis, that lots of patients can have tuberculosis and not be aware of it. So every patient before starting a biologic should be checked for tuberculosis. And also, this isn't a good choice if you have multiple sclerosis as well. These TNF inhibitors are very helpful for multiple conditions, and they can also help with comorbid conditions, so conditions that occur with your specific condition that it's used to treat. So often if patients have uveitis with their back inflammation, or they have inflammatory bowel disease, it can be very helpful for this, as well as psoriasis as well. So we'll talk a little bit about psoriatic arthritis. So TNF inhibitors are good for psoriatic arthritis, but we also have other options. So psoriatic arthritis is an inflammatory arthritis where there's inflammation of the joints, and it's often accompanied by psoriasis and nail changes as well. A large proportion of the patients who have psoriatic arthritis will respond to those conventional agents that Nick was talking about on that timeline, the methotrexate, leflunomide, and sulfasalazine. The criteria to access biologics for psoriatic arthritis is that despite treatment with 2 of these agents, you have ongoing high inflammatory markers and multiple inflamed joints. So if you've tried 2 of these different agents and you have high inflammation and ongoing joint pain, it might be time to swap to a biologic agent. So the TNF inhibitors are very effective for psoriatic arthritis, but we also have other options. So this is the IL-17 inhibitors. This is a class of biologic that targets the cytokine that we call IL-17. The 2 main agents we have in Australia are secukinumab and infliximab. These agents are also used for psoriasis. They're very effective for skin disease and also ankylosing spondylitis, or those inflammatory back conditions. These are generally not the agent of choice if you have any inflammation of the bowel. That's why it's very important that you have an in-depth discussion with your rheumatologist when you're choosing which biologic to start. There has been some risks of fungal infections with these agents, but I don't really see a lot of patients who have fungal infections. Next, we'll talk about rheumatoid arthritis. So rheumatoid arthritis is a very common condition, and there's lots of different agents available to treat rheumatoid arthritis. An important note is that the IL-17 agents are not shown to be effective in rheumatoid arthritis because they just a different way that the immune system is overactive in rheumatoid arthritis to psoriatic arthritis. But the TNF inhibitors have been shown to be very effective. So rheumatoid arthritis is an inflammatory condition where you get inflammation of the joints. So next we'll talk about, there's been a bit of a slop around with those slides. So this is just about rheumatoid arthritis. So a large proportion of patients will again respond to conventional therapy like psoriatic arthritis. So like psoriatic arthritis, patients are required to trial conventional disease-modifying therapies such as methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. And for a lot of patients, this will be enough and it will control their disease. But if despite trying 2 of these agents, you have ongoing high inflammatory markers, you have multiple inflamed joints, it might be time to go to trial a biologic agent. You might need to go backwards now. So this slide is actually about tocilizumab. So tocilizumab is an agent that inhibits the cytokine IL-6. So this is an agent that is effective in rheumatoid arthritis. We also use it in giant cell arteritis, which is another more rare condition where patients get inflammation of the aorta. So with this drug, there are more specific side effects and considerations that are important, and it is often not used as the first-line biologic agent for rheumatoid arthritis for this reason. The specific side effects for this agent is that it can drop your white cells. It can cause your liver function test to go a little bit off, but that often just reverts and is of no consequence. It can increase your cholesterol. And the specific risk is if you have had diverticulitis in the past, there is a small risk of bowel perforation. So this is something that you need to have an in-depth discussion with your rheumatologist about before starting this agent. And for rheumatoid arthritis, we have a lot of options. So we have the TNF inhibitors, we have the IL-6 inhibitors, we have abatacept. So this works slightly differently. It interacts with the receptor that blocks the activation of T cells, which are overactive in the immune system and leading to inflammation. This has been shown to be more effective in patients that have positive antibodies in rheumatoid arthritis. So they're seropositive, the positive rheumatoid factor and anti-CCP. And there's been some evidence that there's possibly a lower infection risk in this agent. So it is a good option as well. And then this is the separate class of inhibitors that Nick was talking about, the tyrosine kinase inhibitors or JAK inhibitors that are not strictly speaking a biologic, but we still call them a biologic because they are an advanced therapy. And so these are small molecules. They're not like the other injectable biologics, which are large molecules why they need to be injected. So these molecules act within the cell to suppress the effects of cytokines, so to suppress the effects of the things that the other biologics are blocking and to disrupt the signaling that causes inflammation. We have 3 different agents available in Australia: tofacitinib, upadacitinib, and baricitinib. So they're all oral tablets. There has been some specific concerns with these classes. So if you have a risk of thrombosis, so blood clots in the past, there's been possibly shown to be an increased risk of that. And there's also an increased risk of shingles in patients on these medications. So it's something you would want to discuss in depth with your rheumatologist if you've had any of these, and we will talk about vaccinations and biologics in relation to shingles later on in the talk. Also, there's been some recent data that those with a high cardiovascular risk who smoke and are over the age of 65 might have some increased risk with these agents in relation to cardiovascular disease and malignancy. So again, these ones are not being used first line anymore just because of those increased risks. And so now Nick will talk about the benefits of biologics.
Thanks, Kate. So we've already mentioned some of the benefits with the biologics, and Kate's gone through a bit of that, but just to emphasize, so we use these drugs because often they are effective, even if the traditional therapies have failed. They are effective in reducing pain. They can prevent damage of the joints and other parts of the body. And they also decrease the risk of inflammation-related complications. So, just in the same way that using methotrexate or leflunomide can do all these 3 things, the biologic drugs can achieve that too. And it's important to remember that, in treating inflammatory conditions, we are actually reducing the risk of complications like cardiovascular disease and possibly cancer too. As well as that, we know that these drugs, many of them can help treat related conditions that patients may have. So as we mentioned, psoriasis, inflammatory bowel disease, some of these same drugs are used in those conditions too. So sometimes it's one drug to treat 2 conditions, which is fantastic. And as well, they may be effective just as a single medication. So for some patients, they require perhaps more than one tablet or traditional medication to control their condition, or even with multiple medications, there's not complete control of the condition. We have the option of either adding on the biologic therapy, or in some cases, the biologic therapy by itself will be sufficient, and we can actually stop those other tablet or those other medications. So that's obviously great for the patient, in that you may only have to take one medication in order to control the condition. And lastly, in general, with the injectable drugs, the dosing is either weekly or second weekly or fourth weekly or even longer than that. So the dosing is actually quite infrequent, and that's preferable for many patients as well. So that's some of the benefits of using biologics. And Kate's mentioned some of the specific risks, but I just wanted to address some of the general risks. So as with any medications that are designed to control an overactive immune system, biologics in general, generally speaking, do have an immunosuppressive effect. Now, some will have more of an immunosuppressive effect than others, and that kind of data and comparison is still being developed. We don't have direct comparisons of all of these medications, but we do for some of them. And as we explain, in cases of rheumatoid arthritis, psoriatic arthritis, we're dealing with an immune system that's overactive. It's too active, and we're trying to bring it down, ideally, to a normal level of activity. And these medications are kind of putting a handbrake, therefore, on the immune system. And so what that means is that if you do get an infection, you need your immune system to go into overdrive. There actually is a bit of a handbrake on it. So that means that if you do get an infection, you should be, in general, pausing these medications if you can, and allowing your body to fight off that infection. So that's the general risk with general infections, that if you get one, being on one of these medications may make it a bit more difficult for your body to fight it off. Now, with chronic infections, those are infections that may have been there from before you even start the medication. We screen for these. So things like hepatitis, HIV, tuberculosis, we have to screen every patient before we start biologics for these, before we start. And as mentioned, certain biologics, shingles is a particular concern, and that's why before the tyrosine kinase inhibitors in particular, we like our patients to be vaccinated against shingles. Now, skin cancers, and specifically here talking about non-melanoma skin cancers, there is an increased risk, a slight increased risk with the use of biologics. And there's also a slight increased risk with the use of things like methotrexate and leflunomide. And really the way to manage this is that we recommend that our patients get an annual skin check. And really that's the recommendation for all Australians anyway, but it's probably a little bit more important if you're on these medications. And then lastly here, in terms of, being on these medications, is there any risk that might increase the chance of cancer? Well, for most biologics, and particularly the TNF inhibitors, we've got good data that's very reassuring that this doesn't increase the risk of cancers in general. In general, for people on biologics, we recommend simply adhering to the age-appropriate screening programs. So that's bowel cancer screening program, regular mammography, and cervical cancer screening. So there isn't anything additional that needs to be done. Stopping smoking is clearly a good choice as well. As Kate's referenced, just for one class of medications and in a specific population, there is some data that may be separate to this, but in general, we do have very reassuring data on the use of biologics in terms of cancer. And then, of course, the drug-specific risks. And I think I did notice in the chat that there has been a question about injection site reactions. So that means for some people, rarely now, at the point where a biologic is injected under the skin, there can be some redness and irritation of the skin. That it is uncommon, but it does occur, and it can occur usually because of some of the adjuvants that are in the preparation of the drug. So not the drug itself causing irritation, but some other chemicals that are in the fluid that's injected. And so actually there are some that have been identified that have been changed in different preparations of the drug. So if you're having that issue, certainly worthwhile speaking with your rheumatologist as to whether there's any option to change or what might be useful in mitigating that. And then another question you may have, are biologics for life? So if you're started on a biologic, when, a very frequent question we get is, so how long do I have to be on this? When can I stop it? Well, for many of our conditions, for most of our conditions, really, we don't have a way of curing things. That means we don't have a treatment that can be given and then stopped with assurance that the disease will not come back. So, rheumatoid arthritis, ankylosing spondylitis, these are conditions that tend to be lifelong. And so, the question is, can you safely be on a biologic for a long, long time? And, the data that we have built up over 20 years now, 25 years, is particularly for the TNF inhibitors that yes, this is a safe thing to remain on, and it is beneficial for that period of time. So obviously every year we're getting more and more data. So we are confident having patients on these medications even for decades now. It is possible for biologic efficacy, whether they're working, that can wear off over time, and in those instances we can switch to a different biologic medication. And there are some instances where, and this is very specific to each individual patient, where you may be able to reduce the frequency of the dosing. So instead of every 2 weeks, maybe that can be stretched out a bit, and maybe even in some cases where the medication can be stopped. But that is very specific to each patient and needs to be discussed with your rheumatologist. So I'll hand over to Kate just to address a couple of other areas.
Thank you, Nick. So we'll talk a bit about vaccination and biologics. So as Nick was mentioning, that the biologics just trying to bring the immune system back down to normal, but we do need to ensure that patients keep their vaccinations up to date. And I think that's very important for the patient. So specifically, flu vaccination should be given every year. I tell my patients for COVID vaccination, it should be given as per the guidelines for the general population. And particularly for the older patients, the regular pneumococcal vaccination is important as well. But specifically for biologics, it's important to realize that if you're on a biologic, you shouldn't be having any live vaccinations. This is because those vaccinations contain the live virus, which could then activate the virus within the system if you have a biologic on board. The live vaccinations are not that common, but the main ones that we have in Australia are the measles, mumps, and rubella vaccination. So if for any reason you're on a biologic and you need these vaccinations, you should discuss with your rheumatologist, and depending on which biologic, it will have to be withheld. For shingles, there's 2 vaccinations available right now. There's one called Zostavax, and that is a live vaccination, so you shouldn't be getting that if you're on a biologic. And the varicella vaccination, which is a chickenpox one, is also live. Sometimes for my patient, it comes up traveling and vaccinations, and a few of the travel vaccinations, unfortunately, are live vaccinations. Specifically, the yellow fever and oral typhoid is what comes up usually with my patients. So it's a discussion you'll need to have with your rheumatologist. And if you're starting a biologic, it's important that you're aware that you can't have live vaccinations. And your GPs who are giving you these vaccinations generally should also be aware of this as well. Now, I'll talk a little bit about the shingles vaccination because it is important for our patients who are on those specific tyrosine kinase inhibitors, but also it's all important for most of our patients because there is an increased risk of shingles as we age and also as you're immunocompromised. So it's important to have that discussion with your rheumatologist. And I do find that there's been some increased community awareness around this. So lots of my patients are asking me about the shingles vaccination as well. The Shingrix vaccination is a non-live vaccination, which has been shown to be more effective than the Zostavax vaccination. It's recently just come approved on the PBS for patients over the age of 65. Unfortunately, it's not approved for patients who are immunocompromised. So it's important that you discuss it with your rheumatologist whether or not that this vaccination is something that you should be getting.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. Otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.